Hello, my name is Amy Sturm. I am at the Ohio State University Wexner Medical Center, and this presentation is on familial hypercholesterolemia. My name is Amy Sturm, and I am an associate professor and licensed genetic counselor in the Division of Human Genetics at the Ohio State University Wexner Medical Center in Columbus, Ohio. I have been working in the field of cardiovascular genetics for well over 10 years, and I was one of two first co-chairs of the Cardiovascular Genetics Special Interest Groups of the National Society of Genetic Counselors. Please feel free to read more about me here on this slide. And thank you for your attention during this webinar. During this webinar, I will be reviewing the clinical signs and symptoms of familial hypercholesterolemia, as well as its diagnostic criteria, the genetics of FH, genetic testing, public health information about FH, its treatment, as well as resources and events that you should be familiar with when it comes to this common yet underdiagnosed condition. Familial hypercholesterolemia, or FH for short, is a very common genetic cause of early onset coronary heart disease, and this is due to lifelong high levels of low-density lipoprotein cholesterol levels. It is an autosomal dominant condition, but it has a gene dosage effect, so that homozygotes who have two copies of the exact same mutation, or compound heterozygotes who have two different mutations, have even a much higher LDL cholesterol in earlier heart disease onset than do heterozygotes who have one mutation. It is a highly penetrant condition, meaning that if an individual has a mutation in one of the common genes for FH, they will likely show signs and symptoms and will likely have high cholesterol and a high risk for coronary heart disease. And we've learned much more about the prevalence of this disorder over the past several years, with heterozygous FH being as common in the general population of approximately 1 in 200 to 300 individuals, making homozygous FH possibly even as common as 1 in approximately 160,000, up to possibly 1 in 1 million individuals. And in the United States alone, it is approximated that there could be at least over 600,000 patients with FH. A recent study published in Nature titled Exome Sequencing Identifies Rare LDLR and ApoA5 Alleles Conferring Risk for Myocardial Infarction found that LDLR functional variants may even be more common than we previously knew. This study conducted whole exome sequencing, or WES, of well over 9,000 patients who had had a myocardial infarction or heart attack at an early age. So these were males under the age of 50, females under the age of 60 with a heart attack. And it compared these individuals to controls, so people who had not had a myocardial infarction at these ages. Specifically, pulling out the data looking at the LDLR receptor gene, they found that individuals who carried variants in these genes had a significantly increased risk for a myocardial infarction. Those who carried a rare, non-synonymous variant, meaning it changed the amino acid in the protein from the proper one to a different one at that position, had over a 4-fold risk for a myocardial infarction, while carriers of a null allele, which means that the protein was not made properly at all, had a 13-fold increased risk for an MI. Also, interestingly, when it was looked at early MI cases, approximately 2% of those overall had a rare damaging mutation in the LDLR receptor gene, meaning that 2% of early MI cases could indeed be due to familial hypercholesterolemia. And among their quote-unquote controls, and again, these were just individuals who had not yet had a myocardial infarction, the prevalence of a coding sequence variant in the LDLR gene was approximately 1 in 217 people. These individuals also had an elevated LDL cholesterol level in their plasma greater than 190 milligrams per deciliter, again showing that the prevalence of FH may hover right around 1 in 200 individuals. Now, in some populations, FH is even more common, and the FH frequency may be even 3 to 5 times more frequent in specific founder populations, including French Canadians, Christian Lebanese, Tunisians, Afrikaners, and Ashkenazi Jews from South Africa, with a prevalence of even 1 in 67. Here we see the estimated percent of individuals diagnosed with FH in different countries or territories. And you can see that in certain countries like the Netherlands, who have systematic screening and cascade screening programs for FH, they have diagnosed a significant number of their patients in their country. However, for some countries who have not had active screening or cascade screening programs, including the United States, Canada, Mexico, and others, it is estimated that possibly even less than 1% of individuals may not be diagnosed yet with FH. Let's talk about homozygous FH a bit more. While it is a relatively rare condition, it has terrible consequences. There's a spectrum that you can see with homozygous FH, but some patients may even present with LDL cholesterol above 500 milligrams per deciliter, with even aggressive atherosclerosis in the childhood years. Cardiovascular disease events even as young as in the first 2 decades of life, and many reports of patients requiring bypass surgery or even dying by age 10. Now, the average age of cardiovascular disease diagnosis from earlier series of patients with homozygous FH was approximately 20 years of age. And here we see an individual who has xanthomas on their hand. Here we show some additional information and some additional photographs of patients who presented with homozygous FH. This patient is actually an asymptomatic 20-year-old man, and his LDL upon diagnosis was 710 milligrams per deciliter. He had plaque in his proximal left anterior descending coronary artery with 80% stenosis and ended up being treated with angioplasty of his left anterior descending coronary artery with 2 drug-eluting stents. On both a statin and ezetimibe, his LDL went down to 300 milligrams per deciliter, but still elevated. And he underwent genetic testing, which revealed him to be a homozygous mutation carrier of a mutation in exon 11 of the LDL receptor gene. Unfortunately, with his delayed initiation of treatment and lifelong exposure to this very high cholesterol, he ended up with these significant coronary artery disease as well as these giant xanthomas you could see on his hands and on his knees. We'll now talk a bit more about heterozygous FH. With heterozygous FH, when patients have one mutation causing an increased risk for the disease, these patients have a 20-fold increased risk of early onset heart disease if they are left untreated and undiagnosed. If they are not treated, men by age 50 have a 50% risk of heart disease. Women by age 60 have a 30% risk. And unfortunately, many patients with heterozygous FH present with already established heart disease in the presence of angina or even a myocardial infarction. Now, the National Lipid Association has put forth screening recommendations, and they have stated that FH should be suspected when the untreated fasting LDL cholesterol is at or above the following. So this is a very important number to remember. If you see a patient who is 20 years of age or older and they have an LDL cholesterol greater than or equal to 190, you need to think FH. For someone under the age of 20 with an LDL cholesterol greater than or equal to 160, you need to think, could this be FH? And for individuals with these levels, the next recommended step is to take a family history and see if close relatives have high cholesterol and heart disease. There are several different diagnostic criteria that have been used over the years to help diagnose FH. Most of them are scoring systems that place individuals into categories of definite, probable, possible, or unlikely FH. Now, all of them take into consideration a combination of the following: whether a patient has elevated, untreated LDL cholesterol, and it's important to know that the cutoff points again vary with age. They will be different for a child compared to an adult. Family history is also key. Are there relatives with high LDL cholesterol and premature coronary heart disease? Does the patient themselves have a clinical history of premature heart disease, or upon physical examination, Do they have things like tendon xanthomas or corneal arcus, which I will show you some pictures of too? And finally, upon genetic testing, is genetic testing able to identify a functional pathogenic mutation in one of the 3 main genes that can cause FH? Now, once the proband with FH has officially been diagnosed and identified, lower LDL cut points can be used to identify their affected relatives, since they are known to already have a positive family tree or pedigree of FH. This slide shows the Dutch Lipid Clinic network criteria, and you can see that they are broken down into different types of criteria, whether it be family history, clinical history of your patient, physical examination findings, LDL cholesterol level, with higher LDL cholesterol values giving higher points, with the highest when you have a patient with LDL even equal to or greater than 330, getting 8 points, which gives you a definite FH diagnosis right off the bat. Also, with DNA testing, if DNA analysis is able to identify a functional mutation in one of the 3 main genes for FH, that also gives an 8-point score, officially diagnosing a patient with definite FH. You can see that when you count up the score, patients can either be diagnosed with definite FH, probable, possible, or unlikely FH. Here we see some of the physical exam findings in FH. Now, first of all and foremost, it's important to know that if you see a patient who does not have any physical examination findings of FH, they very well may still likely have FH. The absence of these does not in any way, shape, or form rule out a diagnosis of FH, because only a small subset actually of patients may end up with these physical findings. Physical signs of heterozygous FH result from cholesterol deposited within macrophages in specific sites. Tendinous xanthomas manifest first as thickening of and then later as deposits within extensor tendons. Tendinous xanthomas can also occur in the extensor tendons of the hands, you can see here, feet, elbows, and knees. Now, arcus cornealis, or corneal arcus, results from cholesterol infiltration around the corneal rim. And whether this is partial or complete in a patient, it's only really indicative of FH if it's present in your patient under the age of 45. In elderly people, they're less likely to be associated with blood lipoprotein abnormalities, for example, in the instance of arcus senilis. Now again, physical signs are insensitive but can be quite specific. The presence of tendon xanthomas should be sought for by careful palpation, not just visual inspection, of the Achilles tendon, and as well in the finger extensor tendons. We can see a broad spectrum of cholesterol levels in FH. Here we see the distribution of serum total cholesterol levels in normal subjects compared to individuals with heterozygous FH in yellow, compared to individuals with homozygous FH in pink. And you can see that there is significant overlap between normal and heterozygous, right around that high 100 to low 200 range of cholesterol. And you can also see that there is overlap between individuals with heterozygous and homozygous FH. In addition, you can see with these bell-shaped curves that there is a broad distribution of cholesterol levels in normal individuals, in those with heterozygous FH, ranging from even less than 200 all the way to reaching 500. And even with people with homozygous FH, you can see their range from 500 to way up to 1,000. And because of this, we know that cholesterol values can overlap. And one thing that is important to know is that LDL cholesterol values differentiate much better between mutation negative and positive FH in children as compared with adults. The overlap problem actually gets worse with age. In 2015, the American Heart Association released a new scientific statement, the Agenda for Familial Hypercholesterolemia. And this includes a lot of great information on patient perspectives, pathogenesis and genetics, natural history and diagnosis of FH, as well as screening, genetic counseling, and treatment for this condition. It includes information on new FH diagnostic categories, based on proposed ICD-10 categories that will hopefully be approved in the coming year. Now, heterozygous FH is diagnosed in the presence of a positive family history of elevated cholesterol or premature coronary artery disease, and LDL cholesterol greater than 160 in a child or greater than or equal to 190 in an adult, confirmed on 2 occasions. Severity of FH should be based on LDL cholesterol level, with a threshold of more than 400 considered homozygous. Clinical manifestations of rapid disease progression, such as xanthomas at a young age or aortic stenosis, indicate very severe and particularly aggressive disease. Now, when genetic testing is performed, classification can be revised on the basis of the results and if they are informative. Genetic testing can provide more precise diagnostic information and facilitates cascade screening in families. Disease in an individual can be diagnosed as heterozygous FH with the presence of an FH gene mutation and LDL cholesterol less than 160. Now, this would be a person that may be identified in the setting of cascade screening. Or heterozygous FH may even be in a person who is severe as homozygous FH if LDL cholesterol is greater than 400. This would typically be in the setting of a receptor null mutation, so a very severe mutation, or if a person has a high number of genetic risk variants that each raise the cholesterol to a certain degree. Now, homozygous FH includes those true homozygotes who have 2 identical LDL cholesterol raising gene mutations. It can also include those individuals who have 2 different FH gene mutations. So these would be your compound heterozygotes. The functional definition of homozygous FH can also include a person with 1 mutation, but who has a very high LDL cholesterol level. So again, these diagnostic criteria are really based overall on how high is that LDL. And this is really necessary because we now know that there is overlap in LDL levels, as shown before, in confirmed heterozygotes and homozygotes, and with the influence of additional cholesterol raising and cholesterol lowering gene variants in any one person. Now, individuals with multiple minor cholesterol raising gene variants are not considered to truly have autosomal dominant FH, but an individual with an LDL cholesterol raising gene mutation and counteracting gene variants that may be protective and lower cholesterol does have FH. And this is because there is a 50% risk to offspring and other first-degree relatives of also having that FH mutation. We'll now move on to review some of the genetics of FH in detail. Here on this picture, you see the surface of a liver cell with the green LDL receptors on the surface of the hepatocyte. On the outside of the liver cell is the blood circulation, and you can see the LDL particles floating in the circulation. ApoB is the pink molecule that is the ligand that actually helps the LDL particle bind to the LDL receptor. Now, FH is caused by mutations in genes encoding these key proteins that are involved in the LDL receptor, endocytic, and recycling pathways. And what this leads to is decreased cellular uptake of LDL cholesterol, and therefore increased plasma LDL cholesterol concentrations. Heterozygous FH is caused either by heterozygous loss-of-function mutations in the LDL receptor, heterozygous mutations in ApoB that affect how the LDL receptor binding domain of apolipoprotein B can bind to that LDL receptor, or heterozygous gain-of-function mutations in the PCSK9 enzyme, whose normal role is to degrade LDL receptors. The severity of LDL receptor mutations can range from very mild to extreme, and this will correspond with the phenotypic expression in terms of how high the LDL cholesterol level is, as well as how severe the cardiovascular disease is. Mild mutations may be those that are usually amino acid changes with more of a weak effect on LDL receptor activity, whereas severe mutations are DNA variants that result in a failure to produce any LDLR protein at all. So with the pathophysiology of heterozygous FH, a mutation in one of these three genes leads toward less functional LDL receptors or less endocytosis of the LDL cholesterol into the liver, ultimately leading toward high LDL cholesterol that can then lead toward the development of atherosclerotic plaque in arteries, causing coronary heart disease and other types of vascular disease, and can lead toward myocardial infarction. This table shows the different genes that are associated with FH. We can see the LDL receptor gene, the apolipoprotein B gene, and the proprotein convertase subtilisin kexin type 9, or PCSK9 gene. Currently, over 1,600 mutations have been documented worldwide in the LDL receptor, and these affect all functional domains of the LDL receptor protein and include single nucleotide mutations, copy number variations, and splicing mutations throughout the gene. The LDL receptor is the most common cause of FH, accounting for about 60 to 80% of definite cases of FH, with ApoB and PCSK9 attributing a smaller amount of FH. Now, it's important to know that there are still patients with FH who will go through genetic testing and not have an identifiable mutation in one of these three genes. And this is because we do not yet know all of the causative genes for FH. It's also important to know that the yield or clinical sensitivity for genetic testing will be higher for a definite FH diagnosed patient compared to one with a probable or possible FH diagnosis. Some studies have shown that the LDLR mutation type will indeed affect the risk for cardiovascular disease. And here we see the Kaplan-Meier curves for early cardiovascular disease-free survival. And this is in men who either had a null mutation, so a completely absent LDLR receptor, or just one that is more defective and a weaker mutation. And you can see here, based on the number of years that these men were able to go on being free from cardiovascular disease, that was lower in those patients with the null mutations in the solid line compared to that of the dashed line who had a defective mutation. So those with the null mutations had a significantly higher frequency of cardiovascular disease at younger ages of onset. To talk about genetic testing a bit more, now we've touched on the fact that clinical sensitivity of FH genetic testing is not 100%, but we know that this is an issue with genetic testing for the majority of genetic conditions we work with in the cardiovascular genetics clinic. Again, remember, LDLR gene testing can identify about 70 to 80% of people with a definitive clinical diagnosis of FH, and maybe up to a third of those whose diagnosis is less certain. Mutations in ApoB and PCSK9 account for approximately 5% and about 1.5% of FH cases, respectively. And interestingly, there may be more than one gene mutation in a family causing the FH phenotype. This may be 2 mutations in the same gene, or this may be 2 mutations or more in different genes. Negative genetic testing, again, does not exclude a diagnosis of FH because the genetic testing is not 100% clinically sensitive. Targeted genetic screening, so for example, in a pediatric population with high LDL cholesterol, has been shown to lead toward higher mutation detection rates with higher clinical sensitivities. And finally, many patients with possible FH may actually have their elevated LDL cholesterol levels due to more of a polygenic etiology. So again, a collection of genetic risk variants that each raise that LDL cholesterol by a smaller degree. The bottom line, though, is with genetic testing, if a pathogenic variant or variants is identified on genetic testing, Cascade genetic testing will allow for definitive diagnosis of FH in all of the at-risk relatives in that proband's family. And this can be very useful for easily identifying who is or is not at risk for FH in a large family. There are many different guidelines that talk about genetic testing for FH. These are from the International FH Foundation, the National Lipid Association, the National Institute for Clinical Excellence, or NICE, in the United Kingdom, the Cardiac Society of Australia and New Zealand. And all of these guidelines overall state that genetic testing should be offered to people with a clinical diagnosis of FH. This will increase diagnostic accuracy, will confirm diagnosis, and when there is genetic testing that is informative, this should be used for cascade testing. We do see overlap of clinical and mutation diagnosis of heterozygous FH. This figure illustrates the fractions of 3 different clinical scenarios. This is in particularly from a study from Spain. You can see that there is clinical diagnosis without a mutation. So these would be individuals who definitely have that clinical diagnosis or have a probable diagnosis, but the mutation just wasn't able to be found. They are up here in this orange category. And for that patient, you need to treat their LDL, and for the family, you may not have a genetic test to do, but you need to monitor family members' LDL and consider treatment if it's high. Now in the middle red, you can see that there is overlap between clinical and mutation diagnosis. So these are individuals that both have the strong phenotype of FH and also have been found to have a mutation in one of the FH-causing genes. And with the patient, you should treat their LDL, and with the family, you would test them to see if they have the mutation or not, as well as monitor their LDL and consider treatment when high. There is also the category of patients that may have an FH mutation, but they do not have high cholesterol. And this may be due to the fact that perhaps they have protective genetic variants, keeping them from having that high cholesterol. You still need to monitor their cholesterol to see if it does end up getting high at some point in the lifetime, and if so, consider treatment, and have that same approach with their family. I would now like to talk about FH through a public health lens, and put this quote on the screen for a moment for you all to take in and read. This is from Paul Hopkins, one of the fathers of FH. In sum, what we know is FH gives us an example of a cause of premature coronary artery disease, the number 1 cause of death of both men and women in our country, and we should be doing more systematically to find patients who have this disease, prevent this disease in them, and screen their families for it. To that point, the Centers for Disease Control, Office of Public Health for Genomics, has classified cascade testing for FH as one of their Tier 1 genomic applications. And Tier 1 genomic applications are those that are recommended for clinical use by evidence-based panels based on systematic review of analytic validity, clinical validity, and utility. So for FH, we need to be doing this cascade cholesterol testing with or without DNA testing in the relatives of our patients with FH, again, to prevent coronary artery disease in a public health fashion. The National Lipid Association Expert Panel and the National Heart and Lung Blood Institute Expert Panel have put forth screening recommendations for children that have been endorsed by the American Academy of Pediatrics. They recommend universal cholesterol screening for children ages 9 to 11, and this is a grade B or strong recommendation. And even more specifically, for children who have a family history of premature cardiovascular disease, and this would be men under 55, women under 65, or if there is a family history of elevated cholesterol, screening in children for hypercholesterolemia should be considered beginning even at the age of 2 years of age. Cascade screening after a FH proband has been diagnosed is also absolutely critical for families with FH. And this is the process of systematic family tracing to identify at-risk relatives. Here in this family tree, you see a pedigree of a family with FH. Red individuals have the diagnosis of FH, and you can see here with the arrow pointing to this 48-year-old male in the square, this would be our proband. And what would be recommended after this is to go to all first-degree relatives. You could see that in this picture, this man's mother was also found to have FH, as well as a son and a daughter. Once you find other relatives with FH, their first-degree relatives should then be screened. And this continues in a stepwise fashion until everyone in the family can learn whether or not they have FH. Again, don't forget, DNA testing should be used if the pathogenic mutation has been identified in the family. Again, newly identified cases provide additional relatives who should be screened, with the bottom line that this facilitates early detection and treatment in this severe disease that is manageable. This type of screening has been shown to be cost-effective in many different studies from many different countries. And it can save resources to go in this stepwise fashion from your proband out in a circular way throughout the rest of the family tree. As touched on, Cascade screening is cost-effective and has been shown to be a great method for identifying new FH patients in several different countries. Many different studies have shown that in order to be maximally cost-effective, this should be systematic, centrally coordinated, and performed using both lipid profile and genetic testing. A study that was performed in the United Kingdom went on to show that Cascade testing from index patients who were definite or possible FH patients was highly cost-effective when it used specifically DNA testing when it was able to be identified in the family, and LDL levels when it was not. There are tools such as Dear Family Member letters created by the National Society of Genetic Counselors that can be used to help proband or index cases share their diagnosis and recommended next steps with family members who are at risk. This letter can be downloaded from the resources page of the FH Foundation website, which I will share with you at the end of this talk. This is the second page that gives family members specific next steps, call to action, where they can learn more, and information on genetic counseling. Now we'll move into talking about treatment for FH. Cholesterol-lowering drugs should be initiated immediately at diagnosis in adults with FH. Statins are the first line of therapy, and many patients will require high-intensity, high-dose, high-potent statins. The goal is to reduce the LDL cholesterol by at least 50%. Women with FH should stop their statins and other drugs at least 4 weeks before discontinuing contraception and throughout pregnancy and lactation. Now, despite use of the highest statin doses, many patients with FH will not achieve their LDL cholesterol target with a monotherapy. So, 2 drug combinations may be required, as well as even 3 drug combinations. And lipoprotein apheresis in homozygous FH and in treatment-resistant heterozygous FH patients who have coronary heart disease may also be required. In addition, if patients are already even on a 3-drug combination, patients may need to go on to having more complex therapy combinations, 4-drug combinations, including some of the novel agents like PCSK9 inhibitors. In addition to drug therapy, it's very important too that patients treat other risk factors aggressively: hypertension, diabetes, etc. Emphatically, we need to recommend against smoking and recommend smoking cessation and actively enroll patients in these programs. And diet and lifestyle management is also important. We recommend that patients should interact with certified dietitian and nutritionists, implement healthy diets, and really involve the whole family, since again, this is a family disease. We need them to achieve and maintain healthy body weight, reduce intakes of saturated fats and cholesterol, and have regular physical activity. Now, in adults with FH, it is recommended that their cardiovascular function should be assessed and that this would be advisable before starting any new or significant intense exercise program. Here we see the LDL cholesterol burden in individuals with or without FH as a function of how old they were when they started taking a statin. So you can see the cumulative LDL cholesterol on the left side, and along the x-axis, you can see the age of the individual. The concept of this cumulative LDL cholesterol burden illustrates the importance of early statin treatment. So if you look at the cumulative LDL cholesterol burden of a 55-year-old person without FH, that's typically a burden significant or sufficient for coronary heart disease to develop. For an individual with heterozygous FH, this LDL cholesterol burden is reached by age 35, you can see there in the red dotted line, if they are untreated. It's reached by age 48 if they're treated since the age of 18, but not until age 53 if they are treated since the age of 10. So again, showing the very important point of starting treatment early so that that threshold for the development of starting to develop coronary heart disease can be pushed back as far as it is able to be. Now, an untreated person with homozygous FH, shown in the light lavender all the way to the left, if they are not treated, can reach this level at the young age of 12 and a half years of age. This study shows that if you compare individuals who initiated statin treatment, and this was a study that began just after the first statin medication was introduced in the Netherlands. So comparing individuals with FH who were on statin treatment in the dark purple line compared to those individuals who had no statin treatment in the red dotted line, and then compared again to individuals who were just from the general population, you can see these Kaplan-Meier curves showing the estimate of cumulative myocardial infarct-free survival with patients with FH. And if they were treated with a statin, their cumulative free survival without having a heart attack reached that of the general population when they were treated properly. So this is absolutely significant in showing why it's so important for patients with FH to be on statin therapy and to be treated properly and to reach that LDL cholesterol goal so that they can reduce their heart disease risk as much as possible and close to that of the general population. Non-invasive imaging techniques of the heart and coronary artery vessels, as well as the carotid artery vessels, can help detect those patients that may not have symptoms yet, but that do have subclinical atherosclerosis. And this is an image showing coronary artery computed tomography angiography, showing identification of subclinical atherosclerosis in an asymptomatic 49-year-old male with FH. And you can see these blue spots on the coronary vasculature that represent fibrocalcified plaques. And this type of clinical data may help change intensification of therapy. We'll also give you some information here specific to treating the pediatric patient with FH. Consideration should be given to starting statin treatment at 8 years of age or older. There have been clinical trials with medium-term follow-up, and they do suggest safety and efficacy of statins in children. They had excellent lipid lowering with no differences in liver transaminases, creatine kinase level, myopathy, growth, sexual maturation, or other adverse events. The goal, again, is at least 50% reduction in the LDL cholesterol or reaching an LDL cholesterol less than 130 milligrams per deciliter. Lifestyle management also remains a cornerstone of treatment for children and adolescents with FH, including a fat and cholesterol-restricted diet. Apheresis is an absolute indication in children with homozygous FH, and when lifelong drug treatment is under consideration, it may even be more helpful to demonstrate that a child, has a causative mutation in one of the genes associated with FH. Also, consultation with or referral to a lipid specialist is recommended. There is a medical need for new lipid-lowering therapies, and this is because a recent study demonstrated that only 21% of FH patients were reaching their goal LDL cholesterol levels, with even newer data that's emerging from the Cascade FH registry showing us that this number may even be higher. In addition, some patients with FH cannot tolerate statins due to side effects from statins. Luckily, many new therapies are in phase 2 or 3 clinical trials, or these trials have even recently been completed with FDA approval. And many of these additional drug therapies can have significant reduction in LDL cholesterol in FH patients. Most of these inhibit specific pathways in lipid metabolism. In January 2013, the FDA approved new drugs for homozygous FH. It approved a drug called Kynamro, which is a mipomersen sodium. This is an injection that can be used as an addition to a lipid-lowering medication and diet to treat patients with homozygous FH. The addition of Kynamro was able to help reduce LDL cholesterol, apolipoprotein B, total cholesterol, and non-HDL cholesterol. This is a patient, Christian Jacobs, who has shared his story with the FDA and serves as an advocate for awareness and is on the board of directors for the FH Foundation. He was able to provide testimony at the public FDA hearing. I think it's always great to hear the patient point of view. A quote from Christian said, "I'm hoping these medicines go through. I'm only 20 years old, and there's so much I want to do. Instead of thinking about the future and what I could be doing, I'm thinking, am I going to have a heart attack tonight?" I'm happy to let you know that Christian is still out there paving the way for patients with FH, still serving on the FH Foundation Board of Directors, and was just recently named the CardioSmart winner for a patient story. Very excitingly, we also have newly approved PCSK9 inhibitors that were just FDA approved a couple months ago. Alirocumab and evolocumab are indicated as adjunct therapies to diet and maximally tolerated statin therapy for the treatment of adults with heterozygous FH or clinical atherosclerotic cardiovascular disease who need additional ability to get their LDL cholesterol level where it needs to be. Evolocumab is also indicated for homozygous FH. There are others in development, and larger outcome studies are ongoing, with hopefully anticipated results in a couple years. Moving on to give you some additional resources to be able to be used for you in your clinic with your patients who may have FH. Here are some resources for you to use in your clinic and your practice. The FH Foundation is a patient-led advocacy and research organization with many different wonderful resources at its site, and they have also hosted an international FH summit over the past several years, as well as launched a Cascade FH registry for patients to enroll into so that we can learn more and more about FH, what patients with FH in the United States truly look like, what their symptoms look like, and how we can best diagnose and treat them. They also have a Find an FH Specialist map. The National Lipid Association is another organization that is really the go-to resource for everything related to lipids and cholesterol. And the foundation of the NLA also has a Find a Lipid Specialist tool on their website. The Preventive Cardiovascular Nurses Association, or PCNA, has a great informational site for FH listed here. And lastly, the National Society of Genetic Counselors has a Find a Genetic Counselor tool. Genetic counselors can help you and your patients, assist patients go through genetic testing for FH, assist family member testing and genetic testing result application throughout a family, help patients understand the inheritance, help family members come in and get evaluated. And there are several resources, Dear Family Member letters, and letters of medical necessity for FH genetic testing that can be found on that site, nsgc.org. Here you see the homepage for the FH Foundation, and again, information on their Cascade screening for awareness and detection of FH registry, a very important registry that every patient with FH should be enrolled in to help us learn more about FH and to also help bring more information back to your patients and families who have this condition. To summarize with the key points, this is not a rare disease. FH is common. I hope I've convinced you of that throughout this talk. And it has a very high risk for premature heart disease if left untreated. But It's treatable and manageable. However, it's underdiagnosed and undertreated, and so we need to do better by our patients and our families who have this condition and make sure that their LDL cholesterol is getting to the level it needs to be to prevent the diagnosis of heart disease in these patients and their families. Again, in an adult 20 years of age or older, the LDL cholesterol number you need to remember is 190 milligrams per deciliter or greater. If you see that value on 2 occasions with no other known cause, you need to suspect FH and take a family tree. Effective treatment really does require that these patients get diagnosed as early as possible. And again, most patients will require high doses of high potent medications and possibly many different drugs in their drug therapy regimen. And it's imperative to initiate cascade testing throughout the family so that we can find else who is in the family that is at risk and who is not at risk, and make sure that everyone in that family is diagnosed and on the proper treatment plan that they need to lead toward prevention of heart disease in these families. Let's find the answer. Together we can do this. Thank you.